Hello, good evening. Welcome to the Eye and Ear Hospital's first GP webinar. Thanks for joining us. Before we begin, I'd like to acknowledge the traditional owners of the land that this webinar is being broadcast and pay my respects to their elders past and present. I'm Dr. Lin F. I'm the GP Liaison Officer at the Royal Victorian Eye and Ear Hospital. My usual working day is Thursday, and you can contact me and some of my team by emailing gpliaison@eyeandear.org.au. I'd like to, in particular, acknowledge our speaker, Dr. Jean-Marc Gerard, who's head of our Otology unit, and for donating his generously donating his time and expertise tonight, and also to the Northwestern Melbourne PHN, who's partnered with us to bring you this event. And we've got Madeline Leonard in the background who'll be troubleshooting. So in terms of troubleshooting, if you are having any technical difficulties or need any sort of technical support or assistance, could you potentially type into the chat section? So if you look at the GoToWebinar control panel on the right, there's arrows and options in the menu. So you just click on the chat arrow and type in what you need, and Madeline's there in the background to assist you. Also, we'd like this webinar to be as interactive as possible. So if you've got questions for the speaker, then please type them into the question section in that same control panel. If you go to the question arrow, point it down and you can type in questions. I'll be moderating those questions and asking our speaker at various intervals or at particular moments. And I think depending on how many questions we'll get, hopefully we will get through all of them tonight, even if we have to go a little bit over time. But if not, we can always have those answers typed and sent out after the event. We will be video recording this event, and I'll let my emailing list know when that recording is available. I presume the Northwest Melbourne PHN can also let everyone who's registered for the event know once that becomes available. We'll have a link from our GP education pages on the Eye and Ear Hospital website. Also, evaluation forms will be mailed out at the close of this webinar. Could you please complete them as soon as possible? If you put it in a to-do list, then if you're like me, it's likely to not get done. We really do value feedback, and we use that feedback to help plan future events. I'm just going to skim through some things, and then really the main most of the hour will be spent on our feature presentation by Dr. Jean-Marc Gerard. So the Eye and Ear Hospital website continuously is being updated with information regarding our services in relation to the COVID-19 pandemic. So if you're not sure what's happening, just check on the website. If you click on health professionals, there's a for GPs and other referrers drop-down menu, and that brings you to this page. There's updated information there about our emergency department, referrals. We're still accepting referrals. Specialist clinics are running at reduced capacity. There's also some appointments being managed through telehealth and telephone consultations. Urgent cases are still being seen in clinic. And we're slowly trying to expand that as well as maintaining social distancing, and you know, that will become more difficult as numbers are increasing. Obviously, surgery has been ongoing in accordance with DHHS requirements, and slowly that's being opened up. So both of our surgeries are now, both of our theatres, day theatre and usual theatre, are both open and running now. And all up-to-date information will be up there on the website. If you've got any urgent clinical advice, as always, please call our switchboard. That's 03 9929 8666 and ask for the eye or the ENT admitting officer. If you are struggling to get the information that you need, you can email GP Liaison, but as I said, I am only in once a week. That email is also answered by our patient liaison officer, Deb Hales, and while she's not a GP, she's absolutely awesome at getting to the bottom of problems, getting patients in, and also looking after some of your particularly vulnerable patients. So it can be a useful resource, but just bear in mind that we have limited capacity depending on our hours. So that's sort of if the usual channels aren't working. And then if you scroll down that page further, you get to other links such as referring to the INEA. So that's this page here. You'll notice we've got ophthalmology, ENT, referral guidelines, but also I want to draw your attention to the Cochlear Implant Clinic referral guidelines just below that, because they're quite separate. So sometimes when you look at our ENT referral guidelines, you might say, age-related hearing loss is not accepted as a referral to the INEA, except that they might qualify for cochlear implants. So please do have a look at the Cochlear Implant Clinic referral guidelines. If you click on them, you get very specific information about the sort of people who may benefit, what sort of hearing thresholds are required, and if you scroll right down, they've got actual contact details. Just contact them directly for referrals. Make sure you note that it is for cochlear implants so it doesn't get caught up in other ENT referrals, and you can phone them or email them directly if you've got any queries about whether your patient's eligible. Next, I just want to briefly mention that those GPs in Victoria may or may not be aware the Victorian Department of Health has set some statewide referral thresholds for specialist clinics, and the tranche 1 included both for ENT conditions. This came out last year. This was done in order to standardise minimum referral thresholds and the minimum information required on referrals across all Victorian public hospital outpatients that offer that service. The new statewide referral criteria and related clinical and referral pathways are now available across all Victorian HealthPathways websites or the equivalent. Alternatively, the statewide referral criteria can be viewed on the official DHHS website. I'm not going to read that out to you. I'll send that to you afterwards in the handout. So ENT was one of the tranche 1 who became available in the 1st of November last year. The idea is to have clear, consistent criteria across all public hospitals. There is a link from HealthPathways Melbourne. These are the conditions that have statewide referral criteria, and you can click on those within HealthPathways, or you can go to the statewide website. And then if you need assistance with managing and when to refer various conditions, if you have a look on HealthPathways Melbourne, if you're within the catchment, but all of those that have statewide referral criteria have pathways in your region. What you need to do is contact your local PHN to request a login for your local health pathways, or you can visit vtphna.org.au/carepathways-and-referral. So HealthPathways Melbourne, I just showed you the list of ENT conditions for which there's a pathway, and there is one for asymmetrical sensory neural hearing loss, so we thought we should mention that given the topic of tonight's talk. As I say, you can request a login if you've never done that before through the North West Melbourne PHN if you're in the area, or through your local PHN. I'm not going to go through that because Dr. Jean-Marc's going to talk about hearing loss tonight. I will just introduce him now. Jean-Marc Gerard is an ENT consultant at the Royal Victorian Eye and Ear Hospital and Austin Health since June 2017. He became the head of our Otology unit at the Eye and Ear Hospital in April 2020, so very recently. He's qualified in ENT surgery with a specific interest in otology and neurotology. Prior to moving to Melbourne, Dr. Gerard created and managed the otology unit at the Cleveland Clinic, Abu Dhabi, between 2014 and 2017. In 2002, after completing his training at the Free University of Brussels, he worked as a consultant in the otology and neurotology department at the University Hospital St. Luc, University of Louvain, and was appointed the head of the department in 2011. Jean-Marc also created and managed the Cochlear Research Centre for Advanced Cephalic Surgery in Brussels. Academically, Dr. Gerard was appointed co-chairman of Otolaryngology in the Faculty of Psychology and Speech Therapy, Catholic University of Louvain, and Free University of Brussels, Belgium in 2011, and associate clinical professor in the Department of Otolaryngology at the University of Melbourne in 2017. So that's it from me. I'm going to hand you over to Dr. Jean-Marc for our feature presentation about hearing loss, cognitive impairment, the management of that, and how useful they are.
Well, good evening first. I need Madeleine to re-ask me to share my screen. That will be the first step because I went too quick and I say, no, I don't want to share. So yes, I want to. So you have to send me the items again. Here we go. Here we go. So good evening. Thank you very much, Lina, for your very kind of long introduction. So it's a lot of title, but no, I don't deserve them. Anyway, thank you very much for that. Thank you very much for attending this webinar. It's a bit strange as a speaker, you know, to just face your screen and your presentation. I believe on your side is a little bit better because you can have a glass of wine. French will be perfectly appropriate for tonight. If I'm a bit, you know, not able to entertain you, you can always keep an eye on MasterChef. So that's probably easier for you. Anyway, I will try to entertain you as well as I can. And the presentation tonight, it won't be very technical and very specific. It's more informative. It's just a way and a reflection, you know, about hearing loss, eventually, you know, the relationship with a cognitive disorder and hearing loss. And at the end, you know, I will just try to brief you quickly about what we can do for hearing loss and what is in our portfolio to basically help deaf patients, but also indirectly to prevent or to reduce the risk of, you know, increasing of cognitive disorder, reducing the risk of increase of dementia. I try to change my screen. So there is always, you know, technical issue at the last minute. Everything was working very well. So now my presentation seems to be blocked. And I will do one thing to try to unblock it. Here we go. That seems to be perfect. Here we go. So we always face technical problem with too much technology. So just on the first slide, you know, it's a simple, you know, slide explaining a little bit what, you know, the intensity of sounds mean. And you can see illustration of different intensities. And in our life, of course, we are exposed to high intensity noise. And we know generally that everything above 85 degrees is potentially toxic for our ears. So that's something important to know. And of course, when you have a patient asking you, you know, when should I protect my ear from noise exposure? But, you know, remember that that 85 is the key level of intensity is quite important. Anyway, it's definitively not our first interest today, and we are going to move to the next slide. So quick slide about how the hearing works, and it's an evidence for most of you. I just want to remind you that there is basically two parts of the hearing. You have the mechanical part, and the mechanical part starts when the sound enters the external auditory canal. Of course, the sound is going to shake the tympanic membrane, shake and vibrate the ossicular chain, and finally mechanically stimulate the inner ear and stimulate the hearing cell, which are connected to the nerve, and then the nerve guides, the sound to the brain. When we speak about mechanical hearing loss or conductive hearing loss, it means that there is something going wrong between the entrance, or a blockage of the external canal will create a conductive hearing loss. If you have any condition of the tympanic membrane, any missing or defectuous ossicle, you are going to have what we call a conductive mechanical hearing loss. When something goes wrong in the inner ear, in the cochlea, or with the nerve, we have what we call a sensory neural hearing loss. So it's mostly, something going wrong in the neurological part of the hearing. And finally, you can always have, of course, a mix of both. You can have a mixed hearing loss, which is a little bit of mechanical hearing loss and a little bit of sensory neural hearing loss. So it's important because I will say, in general, mechanical hearing loss can be fixed by surgery most of the time, where inner ear or nerve hearing loss can only be helped and cannot be fixed except in very, very specific conditions. I won't go through them. So when it's a neurological issue, an inner ear issue, we cannot repair it. We just, can help the patient to improve the hearing by increasing basically the stimulus, the hearing stimulus we send to the inner ear. You see this example, and that's a good illustration of what happens when you, for example, just get old and you start to lose your hearing. So on the left side, you see a perfectly normal hearing, and you see a beautiful grass of hearing cells with the outer hearing cell here and the inner hearing cell here. And you see with age and with time, when you start to have a sensory neural hearing loss, what happens, you see the grass is not as beautiful and you start to lose slowly more and more hearing cells. And that leads, of course, to a hearing loss, and that leads to deafness. You see an example here, and unfortunately, losing hearing, it's our destiny. You can avoid it. And I will quickly move back to the slide. You see that's a normal progression of the hearing loss with age. And you see when you are 60 years old, you can, in general, avoid to have hearing loss around the high frequency. But if for, I will say, family reason, there is a predisposition to have, advanced, presbycusis, or if, for example, you have been exposed to toxic noise, you can expect to lose your hearing faster. And you see the difference between someone who is not exposed to noise or not, have the predisposition to have a faster aging of the hearing, or the difference of hearing can be with time. And you see, if you have a predisposition to have hearing loss, that when you are 60 years old, you are like someone who doesn't have a predisposed factors and is 90 years old. So of course it's changed from one patient to the other, and you see that somewhere around 60 years old, our destiny, even if you have a normal pathway, is somewhere to have access to hearing aids because your function, your efficiency of hearing is not good enough and you deserve to be helped. Definition of hearing loss. We know that when you lose more than 40 decibel or 40% of hearing, the efficiency of your hearing is not good enough and start not be good enough to understand. And that's something very important, because when you lose more than 40%, you can increase the sound, but despite the fact that you increase the sound, your understanding will start to be a bit of a challenge. And we know that in adults, when we reach this level, it's basically, in general, the moment where someone complains about the hearing loss, but also when someone deserves to be helped, deserves to try and to get the hearing aid. Children needs more. They need more hearing stimulation. So you see this threshold of hearing loss. So the moment when we need to help kids, it's a bit lower, since, you know, we consider that a hearing loss of 30 decibel and more definitively deserves to be helped, you know, when it's a child. The cause of hearing loss, of course, I will briefly go through it, but you know, there is different causes. From the moment the baby is in the tummy of the mother, from the moment, you know, we are on, you know, the delivery and all the incidents which can happen around delivery, and of course, from the moment you are born, there is a lot of factors which can basically create hearing loss. So basically, when the baby is in the tummy of the mother, there is two big factors. Most of the hearing loss are related to a genetic issue. There is syndromic problems, so associated with other problems than the hearing loss. So you have the non-syndromic hearing loss, which in general are not associated with other problems, and it's only a, you know, hearing loss by itself without any other problem. Around the childbirth, there is infectious, and during even the pregnancy, there is infectious problem which can lead to hearing loss. You know that around the childbirth, you know, low weight baby, premature baby, birth asphyxia, drugs contamination, you know, especially during the pregnancy, can also, you know, create some hearing loss. And, you know, just directly post-birth, there is some incident like jaundice, and that's a common thing which can also create hearing loss, from mild hearing loss to, in general, not in general, to mild to profound hearing loss. And that's what we call the congenital cause. So it's before birth and just, you know, during birth and just after birth. Acquired cause.
Sorry,
you know,
Jean-Marc, can I interrupt you for a moment? I'm just curious. So at those birth incidents, some of them like jaundice can happen after birth. How does that affect in relation to the newborn screening that's done? Can those things happen after the newborn screening occurs? And should we be looking out for them, or is that are they potentially going to be screened by the doctors who are managing that jaundice or whatever it is?
Okay, so most of the hearing loss, you know, congenital hearing loss are screened around birth, but we know that there is some specific situation where the hearing can basically get worse with time. And the typical example is the CMV infection. So the baby can be born with, I would say, normal or nearly normal hearing, pass the screening, but we know potentially that his hearing can be worse with time. And this typical example of CMV, you know, in general, the kids are followed with age, and we sure that, you know, we don't have hearing loss coming with time of follow-up.
Thanks.
So regarding acquired hearing loss, so as I said to you, in this situation, of course, you have two components. You have mechanical hearing loss, which can be due to chronic infection. That's all the middle ear, you know, problem, like the chronic otitis media, whatever the type of chronic otitis media is. And that's the most common thing we are dealing with. You know, you have also when the kids are quite young, and more rarely when we are dealing with adult, all the otitis media with effusion. Most of them, of course, reversible with or without treatment. We know that medicines, some toxic drugs, you know, can create some hearing loss, and you have a quite a trendy treatment for the moment based on the COVID issue, which is the chloroquine, which is potentially ototoxic for the ear. Any trauma of the head can generate hearing loss, and it can be a mechanical problem from a fracture, but also we can sometimes lose, a sensory neural hearing loss from a fracture of the cochlea, or even sometimes a real trauma of the hearing nerve. I mentioned the exposure to noise, so the toxicity of noise exposure. It's depends, of course, of the intensity of the exposure, but the time you are exposed to the sound. And of course, something we cannot avoid is aging. We just spoke about the presbycusis, and that's, as I said to you, it's something we cannot avoid. It's our destiny to all of us. Some are a bit lucky. They won't be impacted too much by the aging, but other patients are importantly impacted by getting old and losing the hearing. Here you see some facts and a number. Well, it's not a new thing. We know that now and in the future we will deal with more and more deaf patients. There is different reason for that, of course, because the population is aging more and more, but we might face also more and more hearing loss due to the lifestyle we'll have, and especially the toxicity of noise exposure. Now we move, and we're going to introduce a little bit, the dementia and the cognitive disorder. Here you see something which is not special. It's basically the definition of dementia. And what might be important to discern is basically the difference between dementia and mild cognitive impairment. So you see when you are just cognitively impaired, it's a mild impairment, it's just when you slowly, start to move from normal to, basically have issue with your occupational and social functioning. So see the transition where you are not functioning like normal, but you are still not completely losing it. Of course, it's a bit vague, but it's definitively well defined in the medicine and directly through assessment. Again, here are some facts, and you see that, by the population getting older, we are going to face more and more cases of dementia. That's something we cannot avoid, and we will speak after, risk factor later, which might influence also this number. And it's going to be a concern in terms of health economy, and also in terms of offering treatment, eventually prevention, following those patients, and help them to keep a good quality of life despite the fact that they are impacted by loss of cognition or dementia. Now we are going to go through the association between hearing loss and cognitive dysfunction. So I will say we start to be interested by this relation. It's not a new thing, but it really started approximately 10 years ago. There was different reason behind, including a bit of marketing issue, from the hearing companies and the classical hearing aids companies, but also a little bit from the cochlear implant companies. So there is a lot of publication, there is more and more publication, there is meta-analysis, putting everything together. And definitively today, we know that there is an association between hearing loss and mild cognitive impairment. And you can see here, when you look at the risk ratio, when you have basically hearing loss and mild cognitive impairment, this ratio increase. It's not a massive increase, but there is definitively something significant, showing the association between losing hearing and indirectly losing a little bit of your cognition. It's the same if you look at dementia, so more important cognitive disorder. This association is also clear, and you see that also this risk factor is not really high, but there is definitively something significant, and there is definitively a significant association between hearing loss and dementia. That's very interesting because here in this publication, you see the relationship between the intensity of hearing loss, and you see on the x-axis, you see someone without hearing loss here, someone with a severe to profound hearing loss here. And you see if you just have a mild hearing loss, the risk, factor is basically multiplied by 2. So there is 2, to make it easy, 2 more chance to have, cognitive dementia when you have hearing loss. If we move to a moderate hearing loss, which is moderate more than 40 decibel of hearing loss, and we are going back to the definition of hearing loss and the threshold when we believe people need to be helped, need to benefit from, hearing aids, for example, you see that this factor is basically multiplied by 3. And finally, when we speak about severe hearing loss, and today severe hearing loss is basically the indication of a cochlear implant, you see this factor is basically multiplied by 5. So worse is the hearing loss, higher is the ratio of having, dementia, higher is the association between deafness and dementia. An important thing, and you see here, what influences the risk of having dementia. And of course, you have a birth issue, which is a genetic problem, early life impact and factors of influencing, the dementia is the loss of education. And around midlife, you see you have hearing loss, hypertension, and obesity. And basically, the factor you can control represent, 35%. So in 2 words, if you want to reduce the risk of dementia, you can only influence 35% of those risk factors. And if you look in detail, you can see that hearing loss, influenced by 9% the risk of having dementia. And it's probably the higher risk, and it's not probably, it is the higher risk, of the risk factor we can modify. So it's very, very, very important to correct hearing loss, because if we correct the hearing loss, we will reduce the risk of dementia by 9.1%. So it's very, very important, and it's somewhere kind of easy to do, and maybe sometimes easier to do than controlling hypertension and obesity. Deafness and cognition decline, and that's quite interesting presentation. So they basically did 2 things. They try to control the risk factor of, cognition disorder. So controlling the blood pressure, controlling the cholesterol, be sure the patient remains active, all the risk factor we try to control on patient getting older. And when they try to do that and improve and control those factors, they saw that somewhere it doesn't, reduce the cognitive, function decreasing. On the other hand, they realized that when they correct the hearing loss with hearing aid most of the time, they can definitively reduce, the evolution of the cognition disorder. So it again proved that correcting the hearing is easy, but it's definitively helping to reduce the impact and the speed of the dementia, getting, worse and worse and worse and worse. So now we can explain that. It's not very clear, and there is a lot of...
Jean-Marc, sorry, can I just interrupt, because there was a question just to clarify. Sorry, I think it was for the 2 slides before. How do you rate the hearing loss from mild to severe? I think was the question was from Christina. So I guess in this slide,
we consider, so moderate hearing loss is an average loss of 40 decibels and more, and a severe hearing loss is 70 decibels and more.
And mild is?
Yeah, mild is, below, it's between 20 and 40 decibel.
Okay.
And we come back to, the definition when I told you in general, we don't care too much about, correcting hearing loss of less than 40 decibel on adults, but above 40 decibel, as I say, you lose this function of understanding, and definitively that's the moment where, in general, the patient is impacted in his day-to-day life by his hearing loss and deserves to be helped.
Yeah.
So going back to the mechanism to explain this association between cognitive disorder, dementia, and hearing loss, as I said to you, it's just not very clear. So there is still a lot of different suspicion, explanation. So the first, which seems to be a bit obvious, but we are not sure about, of course, with age, you just lose more and more cognitive function. And that results in cognitive disorder, and when it's more advanced in dementia. And it could be related to the lack of, stimulation, cognitive stimulation. And of course, it's a basic explanation, but yeah, it can still be the cause. We also believe that the second, hypothesis is to say, okay, you lose your hearing, and to compensate this hearing, you have to use other cognitive resource. And by using this other cognitive resource to understand and eventually communicate, you can basically kind of create a decline of the potential of your cognitive function. So you kind of transfer, you need to transfer, your cognitive resource to the hearing function, and that creates a lack of efficiency in the the resource you use to do that. The other thing, and we don't know very well, we can also believe that we modify the auditory pathway, and the quality of the auditory pathway is declining with time, and that's also associated with the decline of the brain function in general. But that we are a bit back to the first hypothesis. And the last thing, of course, is just a neurodegenerative process. Everything works less and less efficiency with time. So it is still not clear, but we definitely an association between cognitive issue and hearing loss. The impact of hearing loss in our world is quite important. You see a number in America and you see a number in Australia. As I said to you, it has a really significant economic impact on the function, on the quality of life of patients, but also to keep our patient efficient professionally and socially, by trying to correct, the hearing loss. It's also has a significant cost, and it's going to be worse and worse with years. Same thing with dementia. We saw the numbers previously in the slide before, and that has a massive cost. And you see in America, the cost is significant. In Australia, it's also significant. And of course, it's going to be more and more significant with time. And preventing, those conditions will probably also help our health system, not to have to spend too much money on dementia, on cognitive disorder, but they will probably have to eventually spend a bit more money on treating hearing loss. Hearing, and that's important, as I said, the hearing pathway is just not just the stimulation of the ear going through the hearing nerve, going in the brain. So hearing is influencing a lot of other things, as well as a lot of other cognitive things are going to influence hearing. So by losing hearing, you also lose the potential to do other function, to continue to function and to be efficient in other systems, in other cognitive functions. So it's very important to correct the hearing, because you can, of course, improve the rest of the function depending on the hearing system, but vice versa. So it's a very complex system. It's just not like, the sound goes to your brain and that's it. There is a lot of different other function interfering in your hearing pathway in both directions, feeding the hearing pathway to improve the efficiency, but the hearing pathway is going to also feed other cognitive function to function better in your day-to-day life. And of course, when you lose hearing or when you lose cognitive function, this is highly impacted. It's not impacting your quality of functioning, of hearing, of understanding. It has a lot of other impact of different neurological function. This is just to relax and to try to bring back your attention if you lost it. There is a very scary impact of hearing loss, and you see the title of this presentation. It was done in Turkey, so I don't know how scientific it is, but look at the conclusion. So, they definitively show that if you lose mild or moderate, sensory and hearing loss, you have a poorer sexual health. So once again, very important to correct hearing loss if you want to make especially male or eventually female happy. So you see, that's a good way to motivate your patient to go and get a hearing aid. Important to remember. Here it's an interesting graph.
I was going to postulate some reasons for that, Jean-Marc. If my husband's not listening, he's not getting any.
Okay, but it's definitely no good argument to convince him.
Yeah.
Anyway, so that's, I don't know if it's scientific, but it's a good way to, show that or explain that to your male patient first, eventually female also. Anyway, let's go back to something a bit more scientific and serious. So you see this graph is very, very interesting because on the x-axis, you see the age. So it's basically when you lose some hearing. And here you see the functional capacity. So of course, when you are born, your functional capacity is nearly close to nothing. And you get older, you improve your functional capacity with time. You see, if you lose some hearing when you are young, early age, basically, so baby or just after being a baby, and you eventually get an early therapy, which is either hearing loss or cochlear implant, in advanced hearing loss, of course, you can see that by correcting this hearing loss, you will quickly improve your functional capacity, but you will never somewhere be back to totally normal. If it's happened a bit later, and you see that's, as I said, more the congenital issue, when it's happened around the birth or at birth, it's the same thing, early we treat it, more you are going back to something normal. And you can see the baby we treat with a cochlear implant, and of course, a profound hearing loss, they have the potential to quickly go back to what we call functional capacity, but also following a nearly normal curve. When it happens when you are a bit, older, and you see it's late, so adult is the same thing. Of course, you have good function capacity, but by losing hearing, you are going to reduce it. And if you correct it with hearing aid or eventually a cochlear implant, and you don't wait too long, then you have the potential to bring back your function to normal, nearly normal. So what it means, when early we treat the loss of function, better it is, and early we treat it, closer we will be to normal or nearly normal. So it's very important not to leave definitively the baby without hearing, and that's no doubt about it, but it's also very important not to leave adult with hearing loss. They need to be corrected quickly. We don't need to wait. You see that it's a worldwide concern, and that's definitively helping us to militate, to correct hearing loss, to screen hearing loss. So the World Health Organization has put the hearing loss as one of the most important things, to screen, to help and to correct, in the coming years. That's really helpful because it's a good support for the professional of hearing loss, and it's also a good support to advertise, to help those patients with hearing loss. And you see the plan is, of course, they want to develop a system when they cover the rich, the poor, the developing country, developed country. It's really worldwide, and that's very important. They try always to help everybody with, of course, the potential resource we have in each respective country. They want to create an evidence-based strategy, so showing that basically you don't hear well, you need to be helped, and if you are helped, it's going to be cost efficient, it's going to improve the quality of the patient. And we will come back again, to the efficiency of classical hearing head and cochlear implant later, but it's an evidence-based, and it's more and more an evidence-based with time. Vaccination is important, and we mentioned, the risk of getting infectious disease, creating some hearing loss, so more we prevent the risk of infection, more we are going to avoid the hearing loss related to this, to those infections. So vaccination is part of, it seems to be evident for us, but it's not as much evident in, developing country. Screening is important. If you want to find the deaf people, it's not as evident as we believe, and screening, trying to improve the number of screening, trying to facilitate the screening will help us to find patients, maybe not with super advanced hearing loss, but definitively with moderate hearing loss. And we saw before how important it is to correct, moderate hearing loss. The problem is nice to screen, it's nice to find the hearing loss, but to correct the hearing loss, it definitively has a cost. And yeah, they also try to work on, improving the financial access and to reduce the cost of hearing technology. And you will see on future slides, or in certain country and developed country, they try to change the rules and to give easier access to hearing technology to deaf patients. I don't know if you want to do a small pause, Lina, and you want me to answer question on the first part before we speak about hearing solution, hearing technology.
Certainly a chance to remind people they can put questions in the question boxes, but there's no questions waiting to be answered at this stage, and we're at 7:47 now, so I'm not sure how much I would keep going, but I'll keep an eye on the question box. If you've got questions, put them in there and I'll interrupt you, Jean-Marc. Perfect.
So let's speak about how to treat hearing loss, and there is a quite good thing to know. It's nowadays basically whatever the type of hearing loss you have, from mild hearing loss to very profound hearing loss, to mild sensory hearing loss, to moderate hearing loss, from what we call a conductive hearing loss. You can see that on this graph, with normal hearing head, with cochlear implant, with what we call acoustic implant, bone conduction implant, we are mostly able to cover all the different intensity of hearing loss, but also all the different type of hearing loss. There is one area when we still lack a little bit in solution. It's patients who are not deaf enough to receive a cochlear implant, so they still have a capacity, to get the cochlea stimulated acoustically, mechanically, but they have a big conductive component, so we cannot use the eardrum and the ossicle to drive, to stimulate, to shake the cochlea, and we need powerful, what we call acoustic implant to vibrate, the mechanic of the cochlea. And we had a solution. It has been removed from the market for, I won't go into details, but basically it's more marketing issue, I believe. We have new bone conduction implant, which can, slowly help those patients, but it's still an area when we lack a little bit in solution for the moment. But I hope in the quite close future we will have better implant, or we will have new indications which might help us to cover. But very important to know that whatever the hearing loss you have, the type or the intensity of hearing loss, we can help the patient, and that's very important. You see,
sorry, yeah? Jean-Marc, can you just explain the abbreviations on that chart?
Definitely. So you see here, if you have just what we call a sensory neural hearing loss, in general with normal hearing aid, you can help the patient. There is some implantable device when there is a contraindication to wear hearing aids, so conventional hearing aids. Give you a simple example, and don't send us all your patients with eczema of the ear, but if the patient really do not tolerate, something in his ear canal because he got directly infection, we can always put an implant, as an alternative. When you have a mechanical hearing loss, we have what we call the bone conduction implant. So we shortcut, the stimulation of the eardrum or on the ossicle because either they are not efficient or they are blocked or whatever. And we drive directly by vibrating the bone, we drive directly the inner ear. So that's a very efficient solution. It's called the BAHA, We have a new generation of implant which should arrive soon on the market in Australia, and we hope in 2021 we will have the new generation of BAHA, which is a bit more powerful, but also better in terms of quality and a little bit more practical.
And just explain BAHA, what it stands for.
It's basically a bone anchorage hearing implant. So it's basically a system which captures the sound, vibrate, an attachment which is basically attached to the bone, and the vibration of the sound going through the bone is going to directly stimulate the cochlea and the nerve. So we shortcut all the mechanical pathway of your normal hearing.
Yeah.
So evidence, about, correcting hearing and the efficiency of, the hearing treatment we have. As I said, it's nearly an evidence-based medicine, but we never compare two groups of one patient with cochlear implant and the other one without. But today it's an evidence that if you have an advanced hearing loss or you have a moderate hearing loss, once again, you need to be helped. And you see here, it's about classical hearing aid. So when you deserve and you are efficient with a classical hearing aid, you need to get one because, it's going to improve your quality of life and your quality of communication and understanding. You see here, and we spoke about the access of solution. But in Australia, we are quite well helped, financially, but there is still a big part of the patient who needs to pay for the hearing aids, and it has a significant cost. I hope with time it's going to change. I hope hearing solution might be a bit cheaper. I also you can have in America, you can buy hearing aid out of the shelf, out of the counter, so you don't need to follow the entire process. Of course, there is a lot of pro and cons argument, but I think the general idea is definitively to reduce the cost, to let patients benefit from help, and not being restricted by the financial impact of trying to correct your hearing loss. And of course, you can discuss a lot about the pathway, who is involved in it, but the general intention is to reduce basically the cost. And I hope with time, with the competition, with different solutions, it's going to be the case in developed country and developed country in the future also. Interestingly, you see that we speak about cochlear implant, and you see here, it's, the cochlear implantation start in the 80s, and of course in Australia, we all know that since it was done here. And you see the performance, the efficiency of a cochlear implant with time got better and better with the technology, all the concept improvement of surgery, improvement of the electrode. So there is no doubt that today, with the new technology, we are efficient. We are really efficient, and we help the patient to hear better and to perform better in the day-to-day life. It's nearly an evidence base, and it's not only for adults, it's definitively for kids. And you see there is team from the Pioneer, from Australia, who have shown that it's, It's pretty much an evidence-based, even if it was never scientifically proven. There is no doubt that when you don't hear and when you have an advanced hearing loss, severe or more, you deserve to get a cochlear implant. Interestingly, you see that more and more implants in the world with time, but somewhere the cost of implants remain the same. I won't go into the discussion of it, but once again, it's the same thing. We want to implant more and more patients, but somewhere the cost is still the same. So it has a significant cost to our health system. And that's part of the thing we should consider if we want to implant more and more patients, if we want to help more and more patients. Other interesting thing, you see the number of adults receiving cochlear implants, developed economies, emerging economies. Interestingly, you see the old patient over 65, they represent, I would say, pretty much 20% of our implanted population. But we still believe that we only implant 10% of the old patient who deserve to get an implant. That's something we are working, we are promoting, we try to communicate like I do tonight. We try to communicate directly to the family. We try to find solutions to have a better penetration of cochlear implant in all patients who deserve it. And you see, in comparison to emerging countries, they don't even consider to implant all patients. They are more focused on kids, which is, of course, one of the biggest priority, but they forgot to take care of the old patient for different reasons: screening, targeting, not believing that it's a cost-efficient treatment. There is a lot of reasons behind, but definitively you see that more we are going to screen, more we are going to communicate, more we are going to be able to help patients, and there is a massive potential behind. As I said to you, Australia is after Belgium. No, Australia is first, but both are very, very, very good, and it's definitively one of the best countries in the world to have hearing problem, because you have access to fantastic service, you have access to the best technology, you have access to really the leading people in the world in terms of indication, in terms of technology, and in terms also of the quality of what you can get, not only for surgery, but in terms of technology and everything like this. And you see there is a lot of different resources. And as I said, there is still, unfortunately, a group of patients where when they need a hearing aid, they have to pay for it, and it has a cost. And unfortunately, a lot of patients, they have to think twice about spending money on a hearing aid. But I deeply believe that should improve with time. It has a massive impact on the health economy, but with time and, finding out this good ratio between cost efficiency and also this relationship with correcting hearing loss and reducing the risk of cognitive disorder or dementia might improve a little bit and might help patients to benefit at a cheaper price from a hearing connection. I will say that's it, because that's very, I already went through it. It's like this small region of mixed hearing loss where we still need to work to develop better. We still need to find a way to help patients, but I've discussed that before. So I would say in terms of summary, let's be simple. So I said from the moment you reach, it's easy to summarize it. When you have a patient saying to you, when I'm in a social situation, I start to struggle to understand. Despite the fact that I ask people to speak louder, or I increase the volume of the television, I struggle a little bit to understand, except if I really lip read. In general, it means that this patient is at the level when he deserves to get the hearing aid. Cochlear implant, I will say, to summarize it, from the moment the patient uses a classical hearing aid and do not perform well enough, so I will say do not understand telephone conversation, do not understand a bit more than half of the words, with his hearing aid, he needs to be referred, he needs to be screened to be sure that he is or not a cochlear implant candidate. And once again, it's very important for us, and especially with the support now we have around the world and with the World Health Organization, we need to continue to, publish some guidelines, public or evidence-based, to communicate, to try to really, you know, have a better penetration, to oblige people to get the hearing screened, and also, you know, to be helped if they deserve to be helped. Thank you.
Thanks, Jean-Marc. That's great. There is one question there, which maybe your second last slide was an answer to. So Christina Port writes, if I understand correctly, cochlear implants can help the conductive and sensory neural hearing loss?
The cochlear implant, so it's basically when you cannot get anything from a mechanical stimulation of the cochlea. So it's when basically the neurological part of the hearing, it's too down and it needs to be basically stimulated electrically. So of course, when you have a mixed hearing loss, if you have 70% of neurological hearing loss and 20% of mechanical hearing loss, even if we correct the conductive hearing loss by 20%, the patient will still be, you know, exactly. And of course, then he is a candidate for a cochlear implant. If you take the example of a cochlear implant.
Does the cochlear implant, it bypasses all the mechanical parts anyway, so it doesn't matter whether they work or not?
Absolutely. And as I said, you know, it's if you have a patient, for example, with 40% of neurological sensory neural hearing loss and an extra 40% of mechanical hearing loss, if you correct the mechanical hearing loss with surgery, for example, and you do a good job, you are going to bring the patient around 40–50% of hearing loss. And then you can put the hearing aid and it will still be efficient. If you cannot correct the conductive component, so you cannot correct the mechanical way, as I said, you can shortcut the mechanical pathway with all these bone conduction implants. And those bone conduction implants need still to be powerful enough to stimulate the inner ear, the sensory neural hearing loss. So give you a practical example, you put a bone conduction implant on a patient with 40% of sensory neural hearing loss and 40% of mechanical hearing loss. If your device works well, you will probably bring the patient to a hearing threshold around 30 decibel. So you see, it's very important. So to summarize it, it's easy. If you have a significant mechanical hearing loss, we always try to correct it surgically. If we have a moderate hearing loss, so only moderate sensory neural hearing loss, we in general help with a classical hearing aid. And finally, if we have an advanced sensory neural hearing loss, then you know you can shake everything as much as you can. You will never stimulate enough, you know, the nerve and the inner ear, and then you need a cochlear implant. But it doesn't matter. It doesn't matter. As I said, what is important for for you to remember, as I said, patient doesn't understand when he's in a bit in a noisy situation, despite the fact that he increased the intensity of the sound. He needs classical hearing aid. If he doesn't understand the phone or a bit more than 50% of the words with his classical hearing aid, he is potentially a candidate for a cochlear implant.
Yeah, great. There is one more question, but we're kind of going over time now. Perhaps before, maybe I will go on for those who want to hold on for that last question. But before I do, I'll just remind people to fill in the evaluation. It will be emailed as this webinar closes. So if you could do that straight away, then it's done and dusted and you don't have to not remember to come back to it. Thank you so much, Jean-Marc Gerard. It's a great presentation, and obviously you really want to continue to advocate for the availability of all these devices and technology worldwide, and including within our country where we pay a fortune for cochlear implants, as you say, and now we're using them more often, but we'll see what happens with that. And thank you to the Northwestern Melbourne PHN and Madeline for helping. Really, without her help, we could not deliver this webinar. So that's excellent, and we really have a great ongoing relationship with the Northwestern Melbourne PHN that have supported all of our GP education events. I do want to just mention, save the date for our next webinar, which will be an ophthalmology topic, sudden loss of vision. That will be presented by Dr. Dean Al-Sayed, and that is going to be Wednesday, August the 19th, if I remember correctly. I haven't written it down in my paperwork, but that is not open for registrations yet, but we'll be emailing. Keep an eye on the GP education page, sign up to my emailing list, and keep an eye on the Northwestern Melbourne PHN event calendar for that. And so I think that just leads me to Jean-Marc. I'll just read out the last question that is there. It's a little bit off topic, but are there any new developments in otosclerosis management?
The answer is not really. So as I said, in most of our patient surgical solution remain, of course, the first thing to think about. When we have what we call advanced otosclerosis, so that means you have the mechanical blockage of the stapes, and on top of it, you have the faster aging of the inner ear, so a neurosensory neural hearing loss getting worse and worse and quickly worse and worse. It's again the same thing, you know, when the conductive loss is important, the first thing you do, you correct the conductive hearing loss, and most of the time is with a stape surgery. When the neurosensory neural hearing losses start to be important and significant, you know, sometimes you deserve to have a cochlear implant. The only issue we have with otosclerosis, sometimes we are facing a calcification, an ossification of the lumen of the cochlea, and sometimes inserting the electrode of the cochlear implant is challenging. And that's our job, to find this good compromise between waiting, you know, when you can still use classical hearing aid, or we can still benefit from a normal surgery, and pushing for the cochlear implant, not to wait too long and to face a situation where we cannot insert the cochlear implant. And the last thing I spoke about, the new development of those acoustic implants, we will be able to help those patients with advanced mixed hearing loss, or a component of both. So that can be an in-between solution for the patient who are not efficient anymore with a classical hearing aid or just a surgical correction, and who are still not perfectly a good candidate for a cochlear implant. So that's the solution we have. So correction, again, we don't have any other treatment to stop the process of otosclerosis, or anything we have tried so far is not super efficient, and in general they are very complicated and aggressive treatment. We don't do really rarely.
Okay, I think that's our last question. Thank you so much, Jean-Marc. Thank you, Madeline. Save the date, the August the 19th, Wednesday night, 7 p.m. for sudden loss of vision. I'll let you know when the registrations are open for that. And don't forget to fill in your evaluations. So I think we could probably sign off now. Thank you everybody for attending our first webinar. Really appreciate it. I'll let you know when the recording becomes available if you needed to review it. Okay, I'm going to say good night to everybody. Enjoy.
Good night. Thank you.